Hi, I'm Ann Greiner, President and CEO of the Primary Care Collaborative, and I'm delighted to have you here today for a conversation about empowering collaborative primary care with ethical use of AI. We've got a fantastic panel who I will introduce shortly, but let me first go through a couple of quick housekeeping items as people are coming into the webinar. All of your lines are automatically muted. You probably know that by now. We're going to take questions from the audience in the last 10 minutes. So as you think of them, please put them into the chat and we'll select from those questions. We record this webinar and we will post it with the slides within 24 hours. Immediately following this webinar at noon, the Milbank Memorial Fund and the Physicians Foundation will host a webinar to release the 2024 Primary Care Scorecard. There's a link to join that webinar for the release, and we strongly encourage you to do this. I know there's a lot of content here back to back, but both of these, our webinar and theirs, are very exciting, and we hope that you will stick around for theirs as well. For those of you who do not know the Primary Care Collaborative, we are a membership organization of over 70 members that are incredibly diverse, but our members share a common commitment to strengthening the foundation of any high-performing healthcare system, and that's primary care. And we work together around research, primary care models, payment and delivery, and policies that strengthen comprehensive primary care. Our webinars we host monthly. They are free of charge. They are all on primary care topics, and we have all of our past events on our website, thepcc.org. Okay, today's topic. AI has been an interesting and topic that is on folks' minds, but I think generative AI has really brought it to the forefront. We know that there are many benefits and indeed challenges with AI. So we've got an incredible panel to discuss those. A practicing primary care clinician who uses AI and also supports primary care physicians in value-based payment models. A primary care clinician who works on an AI company. A former Hill staffer who worked on technology issues and now is part of a multi-stakeholder organization that includes consumer organizations. So it's going to bring that perspective. And finally, a physician who leads a multi-specialty organization of physicians across the spectrum and is a thought leader. Will contribute her perspectives about the role of AI from that of clinicians and of patients. So let me introduce each of them, and then we will get underway. Dr. Rowan Gordon is the head of medical practice at Navina, which is an AI-powered primary care platform. And he brings a lot of experience from his previous roles. He was clinical director at Nanox AI. He was also at Deloitte, and his expertise lies in developing technology to support clinical workflows and promote the adoption of these technologies, with a focus on addressing challenges such as burnout and improving value-based outcomes. Dr. Helen Burston is CEO of CMSS, which is the Council of Medical Specialty Societies, more than 50 specialty societies representing 800,000 physicians. Wow. She also previously served, and this is where Helen and I overlapped, as Chief Scientific Officer of the National Quality Forum. And prior to that, she was at the Agency for Healthcare Research and Quality. She's a prolific author and thought leader. Dr. Lynn Jaffe is the owner of DTC Family Health and the Aledade Local Medical Director in Colorado. And so she really brings that frontline perspective. She's an early adopter of technology, and I think she's here to relay how that's working and where there are challenges. And then finally, but not last but not least, is Brett Meeks. He's Executive Director of the Health Innovation Alliance and Vice President at Horizon Government Affairs. In his role as an Executive Director of HIA, he leads a coalition of patient groups, employers, payers, and provider organizations advocating for access to high-quality, technology-enabled care. Prior to that, he was Deputy Health Policy Director on the Senate Help Committee, where he helped write the 21st Century Cures Act. So as you can see, we've got this incredible panel, and really looking forward to this conversation. So let me throw out the first question. When we as an organization, the Primary Care Collaborative, thinks about different technologies that can shape primary care, because that's our focus, we start by considering how technology either supports or detracts from what we're trying to achieve with high-performing primary care. And we look to the 7 principles, which really represent our visionary model of primary care. Many of you are familiar with those, but let me just give you a moment to take a look in case you're not. These principles have been endorsed by over 350 organizations across the spectrum with respect to stakeholder type, and they were developed with the input of over 100 organizations. As we go through them, I think you'll understand a little bit more about how these principles actually work in practice. So my first question for these incredible panelists is, how do they see AI supporting this aspirational vision of primary care? And let me first turn to Rowan to kick us off. And I think, Todd, if you could pull down the shared principles, I'd appreciate it.
I thank you very much, Anne, for passing to me. And it's great to be here and to be speaking to all of you today. I'm kind of here wearing 2 hats, one as a clinician and one with the AI development hat on. So I think looking at the 7 principles, and one of the reasons that Naveen has partnered with the PCC on this webinar is that we feel a strong connection to really all of them. And what we come to do, and I think AI in general has the ability to take chaotic data, take more and more data sources, right? If we think 20 years back, we were probably not getting enough data, and it's not taken very long to be at the point where we as physicians at the front line are getting too much data that we have to try and understand. And lots of our connections to patients really work around data. Just to call out on a couple of the shared principles that I think with my AI developing hat would want to speak to. I think one is around generating high value. Whichever health system we're in, we need to make sure we're using resources as best we can, right? And we're allocating those in the right places, and we're doing that in the most efficient and effective way. And to me, what underpins a lot of that is our ability to have the right data understood with clear insights in the right place at the right time. And I know that's one of the things we're working hard, and we'll see it through this webinar, and Dr. Joffrey will speak on it, but we're working hard to make sure that we can drive high value. And I think the other one I would just call out before I pass back, Anne, is around team-based collaborative work. I think technology has to speak to technology, right? We're always going to live in a world where we have many systems that we use to practice medicine and to improve the lives of our patients and ourselves, right? And to improve our lives. And making sure we have different team members, be that in a small practice where we have just 2 or 3, or even in large organizations where we have many teams who have to be able to collaborate. I think that's another one of the principles I'd say is definitely something I have an affinity to with my AI developing hat on. So yeah, I think I'll pass back to you, Anne.
Terrific. Thank you so much. And clearly, if we don't have good information flow, then teams really can't work as a team. I mean, that's absolutely critical. Helen, your perspective.
Yeah, thanks so much, Anne. I just want to build on 2 points Ronan had made because they're so important. I think in particular, this idea of all that data flowing to clinicians is both wonderful and problematic. And so I think the ability of these systems to actually pull out the important information and signal that we need is such a clear value of what these systems can build, particularly as we think about care increasingly being team-based, as Ronan said, but also thinking about team crossing specialty and discipline and setting. We have patients that flow in and out of settings. So really being able to use all of that in that way. But I think broadly also the ability of AI to just make the work of primary care easier, right? The ability to potentially take some of the administrative burden, often referred to as part of the National Action Collaborative that NAM's been doing on well-being, of sort of getting rid of the stupid stuff, right? There's just so many administrative tasks that don't require the level of a clinician to engage. How do we use AI to do some of the portal task management, for example, to really give more time for primary care docs and others to have the opportunity to really engage with patients, make primary care and clinical medicine more attractive, make it something you want to engage with patients and do what you went to do in the first place. And then hopefully, and we'll talk more about this, but I think a big part of that also is then potentially decreasing burnout, which we know is a huge issue for us across specialties. And really importantly, as we're losing docs to burnout, we also have to think about ways to make primary care look more attractive, which has been a big hard sell for us. And the more we can make the work of primary care seem to be the rich part that we all know and love, which is the relationships with patients, the ongoing care we're able to provide, the collaborations with other clinicians, the diagnostic puzzles, all the things that we love. That's what draws people to primary care, but they're so overburdened by these burdens that I think AI could really help with. So very excited to see what is possible. Thanks.
Thank you. And getting rid of the stupid stuff and reducing burnout and enabling primary care clinicians to actually look people in the eye and not be beholden to, data input, having more time for the relationship because they're not exhausted by all of the administrative work, post-visit, all of those things. I think it really does tie back to from a patient perspective, better access and more patient-centeredness. Lynn.
Yeah, both Anne and Helen have really hit on, for exactly what I want to say, being that physician with the feet on the ground in direct contact with patients. And I'm in a unique situation where I've been in practice for 30 years and my partner retired last month and I've inherited literally hundreds of her patients. And I'm in a situation where I'm meeting 5 to 7 new patients a day. And what AI is enabling me to do is to very quickly get a complete picture of those patients before I go into the room. And I'm now able to sit down and just interact with them and develop that relationship that my partner had with them as well, and engage them and feel like they're being well cared for and that I know what's going on with them. And over again, over the last several weeks, it's been really helpful to be able to, again, have that very quick summary and big picture as well as little picture of who that person is and what they need from me. And again, that is what, as we're moving forward in AI, I'm able to do, again, without all of that junk and that overwhelming, unnecessary detail getting in my way.
Just a follow-up question for you, Lynn. Fascinating to think that you could easily get these patient summaries. How much time does it take to actually get a patient summary now? And what would you have had to have done prior to AI to prepare for these, your first encounters with these? They're not new to your practice, but they're new to you.
That's a really great question. I'm one of those people that likes to prep my charts ahead of time. And for me, I essentially go into the visit with the chart mostly done, right? Because AI, I can see all of the specialists that they've seen in the last year or two and do a quick, snapshot of what they did, their most recent labs, where they're at with all of their quality measures and their mammograms, and very quickly in 5 to 10 minutes, and that sounds like a lot of time, but I've got the chart built so that at the end of the visit I'm almost already done, right? So I'm putting the time in the beginning, reviewing their chart, having that information. So again, it's right there in the AI product that we're using. you know, and it's easily moved over to my chart. It would have probably taken me a half an hour to an hour potentially, depending on their complexity, searching through past hospital visits, last ER visits, the specialist, you know, making sure that their medications are updated. That's all there for me.
Super. So you don't have to do kind of the hunting and gathering.
Right.
You actually can easily get that information and then be ready to go when that new patient walks
Right.
in the door. Sounds
And I'm able to
wonderful.
send it over, which is also a huge issue, right? The ability to not just see it, but not have to retype it, right? And not have to re-grab it, but to then move it quickly into my EHR.
Super, super. Does the patient get that summary?
Yes, they do. And so, and that's incredibly helpful too, because we're double checking. Am I right? You know, are we at that? They're able to see it at the end of the visit because I've got the whole, they're not able to see the AI one, but what I've moved now over into my EHR is absolutely shared with the patient.
That's great. Thank you so much. Okay, Brett, your perspective.
Yeah, that was a great explanation, Lynn, and great answer to is the patient able to see that summary? Because Anne mentioned I worked on the Cures Act, and that's now a requirement that the patient has to have access to all this stuff. And as the person giving the patient perspective, I had a procedure last April. And I've worked most of my life trying to make data flow better in healthcare. I had a procedure last April and had full anesthesia. And a couple hours post-op, you know, it was laid up, and I pulled up my my app in patient portal, and the summary was there, and I was like, yes, like tiny victory, you know. It's getting better, just incrementally. Like, it wasn't a PDF, I couldn't print it, I couldn't share it myself, but it was accessible, you know. It's like baby steps. But I think just to build on what everyone has said, you know, for patients, there is tremendous potential here, but it's all dependent on what everyone just explained. It's this utility and functionality on the back end of the delivery of healthcare to create efficiencies so that doctors can interact with patients. And so patients should have a much better experience because of like what Lynn was just describing. She can actually interact with people. And as a patient, you know, the digitization of healthcare has created you know, doctors typing, right? And so there's less of that interaction, but it should be a much better experience as AI models are becoming more mature and are adopted more widely. So there could be, you know, much better patient experience. And that's really my hope. And a lot of the folks that I work with are really trying to do that. But we have to make sure it's used, you know, the right way. You don't want, there's a lot of concern right now that AIs would make certain decisions, you know, and we have to figure out as society where we want it making decisions and where we don't. I think just to give another, you know, patient example, everything has become more virtual, and part of that's COVID. You know, some of it was already happening, and we got more used to it. But just the patient check-in process, it basically happens over text message now, right? You get or email, and you can check in and go to the front office. And just sit down and be seen pretty quickly. It's a much better experience. At the same time, as a patient and a frequent user of the healthcare system, I'm answering the same questions every time. I understand there's a need for that. Most of it is making sure they have addresses on the claims side, making sure nothing's changed with the patient from a clinical perspective. But AIs can help there too. I don't want to click the same boxes when I'm seeing a doctor every other week, right? So there's tremendous potential for technology to help with these little pain points here and there, so we can all just be humans, right?
Thank you for that. Administrative simplicity for patients too, right? Not just primary care clinicians. Yeah. Ronan.
Yeah, I was going to take an opportunity and you know, just I think obviously an image speaks 1,000 words. Just to build on something that Dr. Joffrey mentioned, and actually take an opportunity to do two things. One is to mention we've spoken a lot about burnout and time in chart prep, and Dr. Joffrey, Lynn, you've mentioned that just now. So I do want to call, and we can share this afterwards, like to the American Academy of Family Physicians. We recently released a report, an independent report with about 700,000 patient encounters across about 1,800 docs. Looking, and they have their innovation lab, and really what we're able to see through AI, like what Navina can produce, is serious reduction in those kinds of things which Dr. Joffrey was just mentioning. So 23% reduction in provider felt burnout, right? So that was a really subjective metric around how do you feel? Do you feel less burnout? And almost 10 minutes of pre-chart time reduction, which is a huge amount when you think how many patients you have each day. And I want to bring to light even just the example Dr. Joffrey gave us, and I'll very briefly, and not a shock to my colleagues on the panel, because we share my screen, and just to give you an idea of what Navina does and what AI is capable of doing in general. So Dr. Joffrey, you mentioned that sort of chart, and hey, I've got all these new patients, and one thing Navina does with AI is mine the data and make sense of it. I don't want to see stuff I don't need to see, and what I do want to see, I want to see it sensibly. So rather than digging around and finding all these documents which don't even have proper titles in my EHR, or finding all these old things, Navina does, and this is the summary Dr. Duffy's using on a daily basis, can put all of that kind of stuff together and make these really quick, easy snapshots, which make sense clinically and give me the time to look at this in probably 20 to 30 seconds and then speak with my patient, which is ultimately what I'm here to do. So just to give you a flavor of what it is Dr. Joffrey's seeing on a daily basis. I think that was one of the questions too. So thank you.
No, that's super helpful to actually see it. And that reduction in burnout is, wow, that's real. And I think we all have to admit that, some of the more recent technology innovations in healthcare have actually produced the worst. They've contributed to burnout. I mean, I think we have to own that, that they haven't actually made things easier for the clinician. So there is this hope that maybe this next generation of technology can do just that. So thank you for sharing that. Brett began to move us in this direction, but if we can imagine, we just heard a number of ways that AI can reduce all the administrative work, estimated to be 2 hours currently of administrative work for every 1 hour of patient care. So, if AI could even cut that in half or more, that would be huge. We know about pajama time, that's after hours care, spent charting and billing and all of that. And that's time away from family and sleep. So if we can reduce that, that's going to be very helpful. To imagine that we can then free clinicians up to actually be in better, have more time for that interaction with patients, that's terrific. We also know AI is doing things like scribing so that people don't need to be heads down taking notes, that AI is helping to do that. So there are, just a lot of applications that we know can really help. I think the other theme that we heard from Ronan is supporting clinicians in value-based payment arrangements, helping to identify care gaps and closing them. So before we go to the challenges, is there any other positive attribute of AI that you all want to lift up? Because then we're going to go to the, sort of the other, the problems with AI and how, as a community, we need to mitigate against them.
I'll just mention something that I think
Yeah,
is both
Lynn,
a positive.
please.
No, please, Lynn, go ahead.
What I was going to bring up is actually, as you're talking about the medical shared savings programs and the value-based care, one of the nicest things, and we're going to discuss this on the other side of one of the complications, is that what has been incredible is that the AI is screening through documents and making suggestions on diagnoses that have potentially been missed. And because of the way the MSSP and value-based care is built, right, our obligation is to describe our patient's complexity at the highest level possible. And what AI is doing for us and what these systems are doing is pulling out diagnoses that are more specific or that a specialist or a hospital is seeing, but because I'm not seeing every single document, I'm not aware of as a primary care. And so it's giving me a bigger picture of that patient, a more complete picture of that patient, and then permits me to describe that patient at their highest level of complexity. So just again, that is one of the side benefits of this because it's pulling information from so many places.
Super helpful. Thank you. Helen.
Yeah, my comment, I think, is really the double-edged sword. I think there are, and I know we're sort of leading into that discussion anyway, but I think there are obviously huge benefits to being able to have at your fingertip the ability to look up just an incredible amount of information using these large language models. And, you know, some of us are a little on the older side, some older than others, but, you know, my residents are all digital natives. They can't even think without anything they would look up on their phone. And they're constantly pulling up, you know, ChatGPT, et cetera, to look up and see what the full expanse of a diagnosis could be. And there's often things listed there that hadn't even entered into our sort of usual differential diagnosis. So for all the concerns, and we'll talk lots about the concerns about some of these newer large language models and hallucinations, et cetera, the reality is just the ability to collect and provide that information at the point of care is really stunning. And we need to learn how to use it well. And certainly we need to understand what are the potential negatives there and the downsides and the black boxes, and really understand what goes into them, understand what the risks are, how to mitigate those risks, and including where there might be implicit bias. We've been doing a lot of work, for example, on race and clinical algorithms. So a lot of race embedded in some of these algorithms inappropriately. And so really being able to have the transparency to understand where things are that shouldn't be, and really doing the work to have a better sense of the continuous monitoring and the evaluation by clinicians and the specialty societies to find out what works and what doesn't, and then build in systems to have continuous monitoring so we know when things are going awry before there's patient harm.
Well, thanks so much, Helen, for surfacing some of the challenges. And can you talk a little bit more about you know, your work to address bias? So what exactly are you know, what are some of the solutions? Because we know bias exists. We want to make sure that as we move to this next evolution of technology, we don't bake it in. So how do you confront that?
Yeah, so there's a couple different ways. I think, you know, at a very broad level, I think we need to collectively understand sort of what's under the hood, and really do the work there. And we had a wonderful keynote at our annual meeting by Mike Howell from Google, who really emphasized to us what our role is as specialties and clinicians, specialized in clinicians, to really evaluate those systems, continue to monitor those systems, assess when they're really ready for prime time. So I think that's really key. A key part of that then is evaluating what comes out of it and looking to see if there is known bias and what's emerging. We have a AI task force that we formed, for example, co-chaired by Steve Waldron from AAFP, as well as Bill Thorath from the American College of Radiology. And we're trying to think through what are those use cases? What are the potential guardrails we need to put in place? Even thinking about a risk matrix. What are the potential benefits? What are the potential downsides? How do we mitigate those risks going forward? It's really a role where we all, it's a place where we all collectively have a role. And I think we need to think about, it's really a unique opportunity, I think, for a clinician tech partnership, right? Also clinician-patient tech partnership, because I think patients, as we're democratizing information in this way, we really need to make sure that they're part of that equation as well.
Well, thank you for that. And let's not repeat, you know, what occurred with the development of EHRs, which I think, you know, clinicians weren't so involved with the development of EHRs. Patients barely were involved, you know, maybe put out some position papers, and, you know, we didn't get the kind of technology that we had all hoped for. So I like the path that you're charting going forward, Helen, and the work that you all are doing is really, really important. Another concern that has been alluded to, and I'd love Lynn to jump in here, is, you know, concerns about the accuracy of the data that you're presented with, particularly with diagnosis. So if AI is going to be a support to you, and maybe you could describe how it could be a support with respect to diagnosis, how can you be assured that the information that's getting served up, you are confident in it, and what can be done to validate that information?
I'm laughing because this is sort of a joke amongst many providers, right? That and one of the nice things is that the AI program that we're using tells us where the data is coming from. So is this coming from a hospital visit? Is this coming from potentially one of the large payers who sends out nurse visits to people's homes and potentially are diagnosing? Our favorite one is peripheral vascular disease, where there's a certain payer that we see that literally every patient that comes from that nurse visit. And so in my practice, we all smile and we decline that diagnosis because that one doesn't have great evidence behind it. And so again, we do a lot of declining of diagnoses that are being suggested, but we also love to see those because it makes us think, right? Is that going on? Did we ask that question? And so I think AI is incredibly useful in at least bringing up the diagnosis and that thought. And then we can, definitively say, yeah, I don't think that's appropriate for this patient. And that's the whole balance of this, right? The whole balance of value-based care and defining who our patients are.
Super, thank you for that. Does it reduce the amount of time spent? I mean, how does that relate to sort of, if AI is supporting you in diagnostics, how does that affect, your clinical time?
That's a really good question, because on the front end, sometimes it does add some time to that, right? I'm screening and looking at those. But over time, the next time I see that patient, the fifth time I see that patient, that is now gone, right? They're not continuing. If your AI program is working appropriately and you've declined that, it doesn't keep shoving it in your face, right? So again, if it's working well. But you're exactly correct. It is overwhelming to us as providers. And, the problem with the way the system is designed, I'm going to use diabetes. There are 300 different diagnoses that fall under the 3 HCC categories in the way that we currently define diabetes in the American healthcare system, right? And those pop up, and you can get 15 of them at one shot. And the truth is they all have essentially the same RAS score, the same weight. I hope I'm the weighting of their risk. And so again, hopefully over time, AI will get smarter and will get smarter and will not be deluged with those 15 diagnoses.
Maybe Ronan wants to comment on this, because I know that's something that you help to support, which is diagnostics. And also, are we reliant? We're reliant on the clinician to be the backstop to make sure that those diagnoses are correct, but can they understand how they were arrived at? Can you unpack that for us a little bit?
Yeah, absolutely. And it's a perfect segue, and I'll take this opportunity for the last time just to share my screen actually and show you that. So this is the example of Navina suggested that this patient may have a diagnosis of heart failure. And firstly, really key, and Helen started us off on this track around. I'm going to talk about accountability in a second, but let me just mention explainability, right? I'm going to put something before a provider, let them understand fully. So just an example. Navina's found a condition that could be relevant for this patient. Being able to say, this is what we found. Here is the document. Here's the date. Let's highlight that. So it's really easy and simple to show you on what benchmark Navina's arrived at that decision. If there's a clinical guideline, that suggests that if the patient's BMI is X, Y, and Z, these are the conditions that can be added. And Anne, you mentioned this. I'll stop there. But Anne, you mentioned this earlier on in the webinar around, there's not just more technologies that add work and burden to providers. It's all the systems we build around. So value-based care is a great example, whether we like it or not. It adds another whole level of admin which we need to do. And Navina or any AI really, taking a lot of that burden away is possible, but there's two parts. One is explainability, right? If I'm going to put something in front of a physician, they need to know where I got it from, why I think it's relevant. Okay, and that includes staying on top of clinical guidelines, staying on top of best practice guidelines, having committees. So for example, in Navina, we have a clinical committee that things pass through. If we're going to make a certain decision, it needs to be reflected. So there's certain amount of work that needs to be done there. And then I just want to mention one other part of this, which Ellen, you touched upon, but there's, it's biases, right? We need to make sure we are constantly assessing our data sets, our demographics, what's missing from that, how that's impacting our model performance. How does our model perform differently on this demographic versus this demographic? And I think any AI company says they do it perfectly is not being truthful to you. But anyone who says they're striving to and constantly at least building processes to ask those questions and make sure we're on top of clinical guidelines that could affect biases, demographics that can affect biases, and constantly striving. So I think that's definitely what, a huge part of it. So yeah, I think accountability and explainability are the key ways. And at the end of the day, if we're transparent and clear about what the AI has done, where it's got it from, and therefore what it's putting before you, that's the aim. And then, like you said, for a clinician, needs to be able to use this and make sense of it and add value from it.
Helen, I don't know if you want to build on that at all.
Well, I want to make sure we give time for Brett. There's so many good questions in the
Sure.
Q&A. I want to keep us
Sure.
going.
Okay, sounds great. I just, when you were leaning forward, I thought you were interested, but I thought you had something to add. Sure, yeah, no problem. Brett, your perspective about, some of these risks that we know we need to mitigate against.
Yeah, I think we just need to go into this very open-eyed, right? In healthcare, we're dealing with people's bodies, right? So it's easily the most important, or their minds, right? But the most important aspect of AI, rollout that we need to really focus on to make sure we get it right. So we've talked a lot about the administrative processes, and I think that's where most of the potential really lies for AI. On the clinical side, I think we're still figuring it out, but making sure that the machines or algorithms, robots, whatever you want to call them, are making the right decisions and that they're being kept up with. So I heard someone say earlier this week on the same topic, we don't hire people and just, all right, here's your job, and just send them out and go, right? We keep up with them, we monitor them. So we're gonna have to do the same thing with AI. And then, for bias, that is a huge concern for a lot of folks in the patient community, that these models won't be trained on the right type of data, or will be trained in a way that was intended to avoid bias, but it actually creates it. There's a great example in New York. Optum had this chronic care management tool that got rolled out, but it did not. It was basically making the wrong types of suggestions to clinicians for African Americans based on the data that it had and the assumptions it was making. So this type of continuous monitoring or operations is going to be required. People talk about having a human in the loop, and that's just so much more important when you're dealing with patient care. Another great example, and I'm sure folks on the line have seen this, is not just the data that we're training it on, but the way that we're programming these things is also important, because if we are tiptoeing around some of these issues and trying to make it avoid bias, it could end up creating inaccuracies. And Google's Gemini rollout was a great example of that. There was a lot of backlash that said, show me pictures of the founding fathers, and a lot of them were Black, and it's just like, well, that's not right. But it was trained in a way where it was having incorrect answers. And so that kind of stuff is very real, and these technologies are nascent. So we make sure that we're approaching this open-eyed in the right way, so that we're developing them to reach all this potential that we had. And I think most of the folks in the patient community that I deal with don't want their relationships with their providers to be replaced by this technology. And what I've heard the clinicians here on this line is saying, no, it's actually going to give them more time to face their patients. So I think figuring out the balance of that to make sure that that's true is what's really important, because there are perfect use cases for AI where maybe my kid's in the pediatrician's office and like waiting for a nurse to call me back. Maybe that's just an AI that I can talk to that's been vetted, right? And that way I can have a real-time response as a parent in the middle of the night. So that's something that could be great. But we don't want that every time. You don't want to wait in line at a clinician's office and have to go to a screen at the side of the room, So I think it's really up to us, in the patient community to make sure it's being developed in the right way, and the clinician community to make sure it's being developed in the right way, and that we are recognizing the limitations of this, both for the data that we're putting it in, the way we're setting up the design of these models, and then how we're using them.
Very well said. And I think you've, kind of put a challenge on the table that, patients are a part of these conversations. And I think that's right. Also that we don't oversell. People get very excited about what the technology can do, but let's be clear, as I think Rowan mentioned, that we're developing how to make sure that we don't have biases. We're not there yet, so let's not oversell. Same is probably true. And here's a question, I'll get right to you, Helen.
Yeah.
AI scribes, maybe they're going to be able to give us more time with our patients, but, there's concerns about their effectiveness and accuracy. So I'd love a response to that. But first to you, Helen.
I just want to emphasize something Brett mentioned about some of the algorithms, like for the health plans, for example. There's very little transparency in that space, so it's pretty hard for clinicians and patients to even fight back or really understand what's involved, because there's so little transparency. So I think in addition to the being able to monitor, look for unintended consequences, transparency of those algorithms is really critical too. So thanks for mentioning that, Brett.
Great. Would anyone like to comment? I'm now beginning to go to the multitude of questions that have come in, and keep them coming. They're great questions. One of the first was about AI scribes, because it certainly sounds wonderful to have, not have to hire someone, to have a scribe be taking down all of your notes, save you a lot of time. But what about the accuracy and their ability to effectively capture what happens in an encounter? Would anyone like to take that question?
Yeah. Go on, Lynn.
We actually gave a trial, and it was admittedly a very short trial. I think there's a lot of training and educating of the system for it to read you and get to know your style for the provider. What we found, and why we sort of backed off at this time, is that it took too much time for the provider to correct all of the inaccuracies. And so, again, for the provider, it actually took more time potentially in the short term. Again, we didn't pursue it long enough to sort of know, but it took a lot of training time for that system to learn my thought process.
Gotcha. Okay. All right. So, a facet of the technology that perhaps is still under development. Maybe there are applications out there that work really well, and so we'll be interested to learn more. Another question is that patient summaries. I mean, I think there's an appreciation, Lynn, for what you put on the table about how they're enabling you to be informed when you are meeting your former partners' patients, and they're now your patients. Um, do they provide the kind of year-long medical history, over many clinics and care sites, or do we need, the technology that you referenced, plus perhaps, kind of personal health record banks, the growing movement there? I wonder if anyone would like to comment. And this question from John Birch said he did not mean insecure systems like HIEs and TECFA, TEFCA.
Maybe I'll jump in initially, and
Sure.
I'm sure my colleagues have something to add. We've all heard this on various forums and discussions. It's only as good as what we're going to give it, right? So if I'm going to try and help a frontline physician like Lynn with keeping her life easier, but I'm only going to look at half of the patient's record to do that, I'm going to do it wrong, right? So there's a lot to be said around how we make sure we have as wide a breadth of data as possible. That could be personal health records. I won't dismiss HIEs, and I think there's lots to be gained through good, integrated data sharing as well. Claims data, EHR data. I mean, let's think forwards. Wearables is not really yet flowing into the primary care or any very specific niche cases. Maybe there's some specialist care, genomics. I think the sort of graph of how much more data is going to need to come is only getting steeper. And I think the more we have, the better we can do with it. And obviously, Brett's already mentioned that doesn't necessarily mean we remove biases, and so we need to do it in a very controlled and clever way. But absolutely, we need to be thinking about, it's not just about getting more and more data, but it's about how is that going to affect what we can give. I think personal health records is definitely one of the areas that there's useful things. And maybe I'll just tie it to another question, which we saw. I think I saw it in the chat. I don't know if it was answered or not, but social determinants of health, that's not always data which is going to be sitting pretty in an encounter somewhere, right? That's stuff which we need to be able to pull from other places. We need to be smart about where we understand that kind of knowledge about our patients' lives, because it's not going to be sitting as we like it, like a lab result, in an EHR.
Very good point. And obviously, understanding. Right. And obviously that's critical information that we would like to have at the clinician's fingertips. Then the next step is, and how do you address those? And perhaps AI can help us with lifting up, an accurate listing of resources in the community, and whether or not they're, able to absorb another referral, etc. So, I think lots of potential opportunity here. I did want to raise. Go ahead, Helen.
I was glad Ronan pulled out that question, because I was going to do it as well. I think that's critical. That's the information that's often buried, and it may not even be in the record, but in this age of being able to do geocoding, and there's just so much. I mean, again, using technology to its fullest means you can pull in other different data sources to be able to pull in, for example, understanding the social deprivation index where somebody lives, for example, could give me, give the clinician a very different sense of what their lives are going to be like, or how hard it is for them to get to a pharmacy, or how many buses they take to come back in, or should their follow-up blood pressure check be all in a portal or telemedicine because it's 2 buses and a train, right? Those are the kind of things that you can actually use by a whole lot of systems that take advantage of some of the information that's in there, that we couldn't just look at it at our fingertips and say, oh, they live there, therefore X. But technology can do that. So much information is available that I think really being able to have the information about social determinants of health can really help improve equity.
Yeah, agreed. And
I think whilst Anne might be looking for the next question to line up, I actually wanted to pose a question just based on some of the comments that we're seeing in the chat and maybe something that both Lynn, you mentioned, and in fact, I think everyone, you had a bad experience with a potential scribe, right? A potential automated scribe kind of thing. And you then stop that. I think one of the things we've discussed a lot, and we spoke about, someone mentioned one of the mistakes around EHRs is, how do we make sure that physicians don't just get put off and say, oh, I don't have time to even think about helping in this. We all have a role to play, Helen, you said it, right? So how do we take those bad experiences or even work with companies like ours to, to make sure that we know how to engage physicians, how to engage patients, and how to go forward so that these bad experiences and our physicians of today don't feel just like disenamored and saying, I don't even have the headspace to think about how this would look. Because if we don't, and that's definitely my experience, and we have a huge amount of physicians and healthcare professionals in the arena, but it's very common that companies don't, and we don't focus on that. So I don't know if anyone's been working on that, Helen, with some of the stuff you've been doing, or Brett, around how do we make sure that to build these things right, we need to engage physicians well, but we have less physicians, they're more burnt out, and therefore there's a bit of sometimes a tendency to say, okay, I'm just doing what I need to do, and I'm not necessarily involved in that. I don't know if anyone's got anything ideas on that.
I want to thank this panel for jumping in when somehow something happened to my internet, and just shows you guys that you are very fast with technology, and you jumped right up. So I apologize for that, and I think the conversation continued. So I'm not sure where it was left, but I apologize for that.
I'll just jump into Ronan's
Yeah,
last point.
yeah.
I do think involving physicians is really important, but I actually would say it's really the team. Like, it can't, if you're not thinking about the role of the pharmacist, the role of the nurse, the role of the triage. I mean, the couple questions there about the different clinical staff roles, telephonic triage, et cetera. And I would also argue the patient. Is the portal even useful for you? Is it giving you the information you need? Really getting that full sort of 360 feedback on these different systems will only make them more valuable in the end. But I completely agree with you. You've got to get that clinical input to make sure it's really going to do what it's intended to do.
One thing to add to that is, we tend to like personify AI already, but it's just a tool, and it's just another thing that we can use and develop to make things better. And for healthcare, and particularly primary care and the team, there's huge workforce issues, right? So having the right deployment of these tools can alleviate a lot of those issues and make the work environment better. So I work with some folks, and there's some members of the Health Innovation Alliance that are thinking about that. They're trying to acquire and use some of these technologies to have a better work environment, to clean up some of this back end stuff, because maybe it'll attract more people to join their team, because they have the best state-of-the-art stuff to make their lives easier and cut down on pajama time. For example, which for me as a parent of young kids is something totally different than clinical notes in the evening. But again, it's the same thing from the patient perspective. If your provider has these cool tools that make it easier for them, it's probably going to translate into them being happier at their job, give you a better experience, and then maybe you have access to more AI type tools to navigate the practice, or even learn about some of this stuff. Health literacy was posed in the chat as well, and I think there's tremendous potential to increase patient education through these tools. To sort of refer someone to an AI that will spend more time explaining these things than maybe a full-time staff would have.
Absolutely.
Yes, and if I can just build on that, because there was another comment in the chat about using AI in a way that also is going to be comfortable with patients. And what I think, Brett, you raised is triage. Well, I'll just say, from a patient perspective, I actually want to talk to, this is personal preference. I want to actually talk to a clinician. I probably have already, consulted Dr. Google, and maybe some of my friends, because I have a lot of friends who are clinicians, by the time I really like pick up the phone, I actually want to talk to an individual, who is knowledgeable and can answer my questions and maybe assuage some of my fears. So, I think we're going to have to find our way through this. Like, when can we use AI, when not? I also had a procedure and there was a follow-up, and what was introduced was, this is a nurse following up on your procedure. It wasn't a nurse, it was a bot. And I really resented that they didn't come clean on who was following up. So I hung up and immediately realized they would just keep calling back until I went through their, answered their questions. But in my patient survey, I noted that and, said, I don't think that's an appropriate place. I think, even if you're just leaving a message, if there is an issue, someone calls back, they need to speak to someone. I just didn't think it was an appropriate place for a bot. Now, people are going to have different views about that. That's what makes it complicated. We're going to have to sort all this out. There's going to be, lots of things that we try and then maybe we pull back from, and others that we accelerate. So other questions that we want to make sure that we answer. I mean, the workforce issues, we're painting this as it's going to really help, and we certainly do have challenges in primary care. But I think there's also the worry that it somehow, it will reduce the workforce. What is your response to that? Or is it just going to get rid of the stupid stuff, as Helen said?
Somebody, I think it's really smart, said at some point it was about radiology, but I think you could say this about almost any specialty, that I think what'll happen in the future is that X clinician with AI will replace X clinician without AI. That's just the reality. You'll be working smarter, better, faster, hopefully engaging your patients in a different kind of way. So I think that's the future, is that we all just have to embrace this. And again, thinking about sort of the entering workforce and the fact that this is just how they live their lives. They live their lives in a totally digital way. So I think being thoughtful about what it's going to look like, and the fact that we have to build it in some way, but being very respectful and thoughtful about the differing perspectives of, your reaction to it might be very different than somebody else's. My thought would just be, hey, they're at least finding out if everybody's okay, and then they can just call back who's not okay. To me, that's an incredible opportunity to save time. But if that's not explained, that's potentially an issue, right? So anyway, I don't want to take the last minute, but just that's a thought.
Yeah. Well, actually, I think, as you can see, these are an incredible group of folks who are working on this issue to bring us new technology, but in a thoughtful way, considering what some of the drawbacks are and mitigating against them, but also accelerating what is really positive. So it's been a delight to spend an hour with all of you. I am feeling even more confident about our journey ahead with AI, that it can be responsible. And I hope that you all have the chance and will continue to assert your leadership so that we can shape it in a way that really is supportive of clinicians and patients. And frankly, we can make our healthcare system more efficient. So thanks so much for joining us today and for your leadership and your the work that you do every day.
Thanks for the invitation. Bye-bye.
Take care.